Good morning, everyone. There's lots of seats still available, so if anyone doesn't want to stand, you're very welcome to come and have a seat. So, good morning. For those of you who I don't know already, I'm Jessica Hopkins. I work with Public Health Services, and I'm very happy to welcome you all to our inaugural joint McMaster Department of Family Medicine and Hamilton Public Health Services rounds. And when we moved in together about a year ago, this is one of the things that we had thought we wanted to do. So it's taken us a little bit of time to get this to this point, but we're really looking forward to this being the very first in what we hope will be a long, enduring set of rounds and a growing relationship between our two organizations. So this morning, we wanted to present to you some talks on the Syrian refugee response. And we thought this was so timely, considering this is something that both of our organizations and many other organizations in the community have been working on very diligently for a number of months. And it's also something where we felt it really put the value of our working together to the forefront. So this morning I'm very happy to introduce, we have 4 speakers. There's one that's been actually added, which is wonderful since the poster went out, but Dr. Julie Emily, who divides her time between public health family medicine. She's also program director for public health and preventive medicine residency program. We have Dr. Eric Junot, who is a resident with McMaster Family Practice. He's also a former Canadian Red Cross disaster management volunteer. We have Laurel Cook, who's a manager of nursing and complex care with the Hamilton Family Health Team. And last but not least, Dale Gunter, who is an associate professor with the Department of Family Medicine and co-director of McMaster Family Practice. And I've also heard that he does a lot of education, and one of the other speakers is one of his former residents as well. So I think they're going to talk about the details of what happened during the response to the Syrian refugees, and also some discussion at the end around population health versus individual health care and how we bring those two together. And there should be some time for questions and answers at the end as well. So without any further ado, I think Julie's up first.
Okay. So I'm going to briefly talk about, is that up there? Okay. I'm going to briefly talk about our planning response from a health system perspective and lay the background for how we approach this issue and how we were able to partner together. So we'll start with health system planning at the local level. So many of you may or may not know, but Wesley Urban Ministries is the designated RAP center, so that's the Resettlement Assistance Program for all refugees that enter into this area. So that is on a usual basis, so they took the lead for the Syrian refugee resettlement response. Wesley, probably in December, I think it was about, assembled a group of healthcare providers to plan for how services would be delivered when the refugees arrived. And so that was a planning table that met before the refugees actually came. At the time that we first met, we expected about 1,000 refugees would arrive between December and March. And so that was what we were preparing for, and ultimately that is what we received. If you look at the health group, it's basically primary care providers who would be able to provide health care support to the refugees on arrival, and then some community services, mostly focused within the city, that would also complement that. So the Hamilton Family Health Team, which was Laurel as representative for that, both community health centers, so Hamilton Urban Core and North Hamilton Community Health Center, McMaster Family Health Team, as you will see in subsequent slides, and how they approached what their involvement was. Refuge, which is a clinic that focuses on newcomer and refugee health. It provides services beyond primary care, so they have primary care, they have consultant service interpreters, so they're not focused solely on primary care. And then we had EMS there at the table. I was a representative with public health, and I don't know if Chris Nagel's in the room, our emergency planner, was also at the table. And then we had the LIN at the table more to get a sense of what was happening across the LIN and what other communities were doing. So we had some perspective. So this group met initially a couple of times in the planning stage, and then once the refugees arrived, the meetings were a little bit more ad hoc. It's important to understand, though, that group was a primary care group really focused on how to provide primary care to the refugees when they arrived. But there were other groups within Hamilton and the health system that were also available to support the response. So we have what we call a Health Sector Planning and Response Committee. It's basically a committee that consists of healthcare players within the system. So hospitals are there, the EMS is there, primary care, CCAC, the LIN, and public health. It is chaired and supported by public health. It first came together during pandemic to decide how we would prepare and deal with the influx of patients. And since that time, the committee meets at least once a year or comes together when there's health urgency. So we've come together in the past when we had a Tamiflu shortage, when we thought we were getting individuals from Sandy Lake when there was a big fire. So that committee also came together with this, expecting that there would have to be multiple supports across the system to deal with this large influx. And then I led a technical group to provide technical expertise. Initially, it was formed to get out clinical practice guidelines and send out a medical advisory. So I chaired it, and I had Linda Redwood-Campbell, Dale was on it, I think, or Linda, I can't remember which one of them. I had Tim O'Shea, Andrea Hunter, Lori Whitehead. And so it was a group of physicians who would have expertise in the areas we thought we would most likely see issues, medical issues from the refugees. So that group met only shortly to provide the initial guidance at the beginning. So the refugees arrived December 6th was the first chartered flight. Because of the amount of refugees arriving, the initial plan was they were housed at Wesley Urban Ministries. They can house about 35 refugees at any given time. And given there was many more than 35, they were also in the downtown hotels. There were about 4 hotels in the downtown that had hundreds of refugees within them while they were waiting for permanent housing. And as many of you may have seen in the media, that took months for them to get into permanent housing, but all are housed now. So the initial plan from the health group was, because of the proximity of the CHCs and their designated role for refugee healthcare, they were going to do all of the initial health assessments, which Eric will talk more about what that means, and that the other clinics would get involved as there was transition to more stable housing. And so that was the initial plan, and that was going forward throughout December and January. And then mid-February, we had 2 cases of chickenpox within refugees housed in a hotel. And so that made the situation different. We suddenly had a potential public health concern, a potential communicable disease outbreak that could spread quite rapidly given they were housed together. And by this point, we'd received, I think we're at 994 refugees. So almost all of our refugees had been received at this point. So as part of our process of figuring out how are we going to deal with the chickenpox cases, part of what we do is figure out who are their contacts, what's their immunization status. We determined a couple of things. Our plans weren't necessarily going as we thought they would, in that of the 1,000 refugees, immunizations were completed in about 50 of them, and health assessments anywhere from 200 to 300, so less than a third of the refugees had seen a physician yet. And some of them had been there by this point 2 months. Some had been there heading into 3 months. And so there are a number of reasons for this. I think part of it was acknowledging that it was a huge amount of data to manage and to schedule and to organize. And so we weren't 100% confident of where we were at. And so that's where we started to figure out some other stuff. So ideally, we would have had better information sharing to know what the status was of the where we're at with health assessments and immunizations. Laurel, I'm sure, will talk a little bit about the challenges that was happening with triage for acute issues. Given, you think about it, 700 hadn't seen a physician or connected with a physician. How do you manage acute issues when they haven't been hooked into care? At this point, they were seeing upwards of 20 people a week going to urgent care or walk-ins and 20 people a week going to hospital. And it was because there was no clear system in place. And I'm sure Laura will talk about the FIT stepped in to see how to manage that. That triage and after-hours services, I think, were linked to why we were seeing people going to places that we would ideally have not had them access care. The transition or plan at the initial that we were going to transition from the CHCs to the other primary care providers at the table hadn't happened yet. There were ongoing challenges with interpreters when you have 1,000 people come, and I think maybe Eric or Laura will talk about that. And it was also identifying, okay, you have these people here, how do you get them to services within our community? Dental was an example. What if they needed to see a specialist? So a number of issues emerged quite quickly when we were in crisis mode and said, okay, let's check in and see how we're doing, and possibly do we need to course correct? And we did. So what happened was that big committee I talked about that involved the hospitals and primary care, CPAC, and the major providers in our community was brought together. And so it was activated because we felt from a public health standpoint we were in an emergency, given the fact we had 2 cases of varicella and potentially could see much more when we understood the immunizations weren't being done. And so at this point there was a lot of information sharing and gathering to say, where are we, what do we need to do? As a group, we agreed to what were our priorities, what would we do if the media called, what are our key messages in the community. Because in situations like this, you want people to feel confident that we have this handled and we're working together. And we had great commitment from the healthcare providers around the table. And I think when you see Eric, you'll see how much they had to do to make this happen. And so public health took over the coordination of immunizations within the hotels to try and get those who are in a congregate setting done. We organized the clinics on site. We had to redeploy, I can't remember how many staff, 130 staff to be able to do these clinics in a quick time. And what we did was complete all eligible immunizations at a single visit, which meant some children got 6 shots at a time, but we needed to do it as quickly as possible to get the communicable disease concerns addressed. The leadership from that health table I was talking about went from Wesley to myself and primary care to be able to free Wesley to deal with the housing and other issues. And from a public health perspective, we're good at managing data and we're good at organizing things. So we had our surveillance team, I see them here, help develop a database so we knew what was happening with the 1,000 refugees. We GIS mapped them to try and pair them to close family practices. We took on the responsibility of identifying a weekly schedule of health assessments, and we were doing there'd probably been 200 completed over 2 to 3 months. We were starting to complete 70 to 100 weekly with the help of all the clinics, and we provided status updates to everyone. And primary care took on a great role. Laura will talk about this triage they provided at the site. Eric's going to talk about the health assessments that were done, and also, as we move forward, taking them into their practices on the long term. So we accomplished a lot. Public health ran 8 clinics. We administered over 1,000 immunizations to 274 clients, and we completed, as I said, all eligible vaccinations at the visit. The health assessments were completed in 2 months, so 700 were about completed in 2 months, 75 to 100 a week, which we couldn't have done without our primary care partners. And by the end of April, all assessments were completed and all refugees were assigned to a primary care practice. Dale, I think we'll talk about, how that's been going since then, but we accomplished what we set out to do. Challenges, I think, are pretty obvious. When you have 1,000 people and they were moving between hotels, out of hotels, trying to keep track of who was where they were, what had been done was a huge challenge. Trying to make sure they came to appointments, because you can imagine the work's done when Dale had prepared to have 30 refugees do a clinic at night, and making sure they got there was a challenge, and having to accommodate a large number quickly was a challenge. And I think one of the things we worked on was how do we work together versus stay where we are. And that's what the success was key. We started to share information, and once you share information, you can work better together. Everyone had to be flexible, because I remember emailing Dale saying, can you do 30 refugees in 2 days? And so we did. There was a lot of willingness on the part of everyone to make sacrifices. I think the fact that we knew each other made it easier, and I think Dale will probably talk about we got to know each other that maybe we didn't know, and so we can use that as we move forward. And I think we all agreed that we were there for a common purpose, regardless of what our own organization's mandate was, and so we wouldn't have been able to do it if we all hadn't come together. So I'll talk very quickly about this because then I think I'm probably at my 15 minutes. Next steps, we've transitioned out of the intense phase. Wesley is still going to lead that operational group who is seeing primary care and seeing refugees, and then I'm leading a health table from the mayor that I report into with Kathy Risden. So again, it's a public health primary care. We're working together on this, and our mandate is to look at, over the next 18 months, how do we ensure that we continue to meet their health needs from a well-being perspective, not just health issues. And so that will be ongoing, and as you can see, there's a number of committees that will support their integration into our community. Okay, I'm done. Hopefully I didn't go over time.
Good morning. My name is Eric Journeau. I'm a resident here at McMaster Family Practice. I was one of the many people involved in helping arrange our response to the Syrian refugee influx here in the city. I'm going to be speaking specifically as to how our response came about, how it evolved over time, and it's going to be pretty specific to our practice as how we did it, but I think it's important to keep in mind how many other practices and health teams and organizations were involved in this. Unfortunately, I'm not able to speak to that stuff because I was not super involved in that part of things. So the initial timeline, just to give you an idea of how quickly things moved, February 26th, we got an email from Dr. Gunter essentially looking for who might be available to help with clinics the next week that we were hoping to hold for the refugees. At that point, the plan was tentatively to go into 3 hotels and do both vaccinations and initial health assessments. Within a few days, we got another email that we were to focus on only 2 hotels and focus on initial health assessments rather than vaccinations and just let public health handle that entirely. On March 1st, there was a conference call with the clinicians who were available, and at that point, the plan had changed again to focus on just 1 hotel, the Homewood Suites across the street. And on March 2nd was the actual response. So you can tell within the period of about 5 days, the plan changed many, many times, and there's a lot of moving parts, but we were able to make it work. So our first day, I don't know why, but we had a cooler as our only containing device for our equipment. We brought some blood pressure cuffs, some gloves, some hand sanitizer, some thermometers in a small Coleman cooler. No organ transplants were done. I don't know why we had it, but that's what we used. And we had a team of 3 staff and 7 resident physicians go over across the street around 5 p.m. To meet with the staff from Wesley and coordinate our first evening's response. We were told to expect about 38 refugees at the hotel. We weren't planning on seeing every one of them in the first night, but that was kind of our set point based on the discussions that we'd had. Turns out there was over 100. And none of whom had their initial health assessments is what I was led to believe. And so that's an accurate representation of what my face looked like when we heard this. But we met with the staff from Wesley, we met with the interpreters, we chatted about what we were going to expect, what we were going to do going forward, and split up into teams and started assessing the patients. So for our first day, our assessments used this template here from the Canadian Collaboration for Immigrant and Refugee Health. It's a evidence-based template for refugees and immigrants from the Middle East. I don't think it's really designed as a charting template per se, and the limitations of the form came up pretty quickly. There's no field for date of birth, for age, for sex, for clinician, so we had to sort of fill in some of the margins. But we saw many pregnant women, some were post-dates, lots of sick kids with URTI-type symptoms, cold, stuff like that. And it was just a bit of a, not overwhelming, but not many of the residents and staff who had been there had experience in this kind of setting, so it was something that we had to adapt to as we went. That being said, we spend years and years training on how to do a history, do a physical exam, make a diagnostic impression and a plan, and you can do that in a hotel, in a plane, in a clinic. It doesn't matter where you are, you can still do that, and that's what we did. But by the first day, we definitely had learned quite a few lessons, and we debriefed at the end of the evening. We spent about 3.5 hours seeing patients. We saw 15 patients in all. We created a Google Doc to share any thoughts. The rooms were shockingly warm. I didn't realize the thermostats could go that high. The equipment accessibility was an issue. Turns out a small Coleman cooler is not the best way to share equipment amongst 3 different floors on a hotel and 3 teams moving around seeing patients. So that had to be changed. One of our residents, Ruben, created an SOP, kind of a standard operating procedure, just outlining what to expect in the visit, which would help in future visits. But it became clear by the end of the day that we needed to change how we were going to do this. Initially, the clinics were being held in the hotels for a few reasons. One, some of the CHCs, if you've heard, had trouble ensuring that all of the refugees who were assigned for that evening would actually make it there, and that's for a variety of reasons, obviously. And we also wanted to make it as easy as possible for these refugees. They've just been displaced across thousands of miles from a war zone to refugee camps to a very unfamiliar and cold place, and we wanted to make it as easy as possible for them. What we heard from the staff from Wesley was that actually many of them would actually, the refugees, the impression that they'd gotten was that the refugees would prefer to actually be seen in our clinic like any normal patient would be, just to make the process a bit more normal and less sort of special or less unique to their population, but a more accurate representation of what people would do here to get health care, which is come to the clinic. So the second day we held our clinic here upstairs at MFP. The patients were brought over to MFP by the Wesley staff, which helped mitigate that issue of low turnout. We had 4 staff and 4 resident physicians present, split into teams with interpreters, and we assessed 16 patients the second evening. All the patients were registered by Nancy Dickey, our one of our administrative staff here at MFP, who registered the patients into OSCAR, which is our electronic medical record software, with their demographic information and their either the IFH or OHIP information, depending on how they were covered, which was very helpful. We were able to chart more effectively, obviously, on our EMR than we were on those sheets. A typical visit would involve one parent with 2 or 3 of their children being seen by a resident or 2 residents and an interpreter. We would address acute health concerns for each member present and then go over and document chronic health issues and deal with anything that we could in the moment. We had some medication samples we could give out, that kind of stuff. Based on this document, these guidelines released by the Ministry of Health and Long-Term Care, which kind of outlined these initial serology and investigations that they had recommended. We did serology for strongyloides, hepatitis B and C, and CBCs in certain age groups. By the second day, again, we learned a lot of lessons. It was definitely more efficient and thorough in our own clinic setting. Everyone had access to the equipment that they needed. We were able to chart appropriately. Dr. Guntrack actually turned that initial template from the CCIRH into an OSCAR template that we could then fill out, but also add fields to. So it was a much more flexible charting method, and it was easier to keep track of the people that we were seeing because of that. A lot of dental needs were brought up to us. In fact, probably the most common acute health concern involved dental needs. So we would liaise with public health about that. Lots of children under the growth curve, which was a big concern for us, and something that we were paying close attention to. Contraception was a huge need. A lot of people, especially the women, were asking about contraception. These are families with 4, 5, 6 children sometimes, and it was obviously top of mind for them. The reason there's a remote control on this slide is that Robin Lennox, one of our residents, on the first evening had a very family medicine moment when she demonstrated the appropriate use of a condom on the only penile-like object available in a hotel room that isn't a penis, and that was remote control for the TV. So thinking on the fly, that was a shining moment in our response. And probably the biggest concern for us was that the follow-up plans were still a bit up in the air. We weren't sure who was going to follow up on this serology. We weren't sure who was going to follow these people long-term, and it was looking more and more like that was probably going to be something that we would be dealing with, just because we weren't really sure how to go forward from here. But there was definitely discussions ongoing on how to figure this out. And by the third day, things were getting pretty smooth. We had 5 teams, residents, and staff. 18 patients assessed. They were all registered the day before into the EMR. Their heights and weights were taken as they came in. It was a very smooth process, or relatively smooth process by that point. One of the hiccups was that a 1 or 2 month old child, a twin newborn, was found to be tachypnic and had some signs of stridor and was significantly underweight, and the presumed diagnosis of tracheomalacia was made at that point, and it was decided to transfer this child over to Mumsy for further assessment. And getting that done was a bit of a nightmare in and of itself. EMS was able to take the mother and the newborn as well as an interpreter, but the rest of the family naturally didn't want to be separated from them, so we had to figure out how to get them to the hospital. And they also had, 2, 3 children and a newborn. We didn't think a bus was appropriate. We weren't sure if taxis were allowed because of lack of car seats. Turned out, I think it was police dispatch told us that a taxi counts as public transit, so you're allowed to go in it without a car seat. I don't know if that's true. I never intend to ask if that's true, but I'm going to use that in the future if I need to. And everything turned out okay there. So the child was transferred to Mumsy. Moving forward, we created a doodle poll to assess clinician availability for the following month. About 40 residents, staff physicians, allied health, administrative staff replied with their availability, and we proceeded to hold clinics about twice a week for the next 4 weeks. I think this was possible partly because we have a big pool of staff here and a big pool of residents who were able to pitch in and help. And some residents, came in for 1 or 2 clinics. Some were there for almost every one of them, as well as the staff. So that was really great. So by the numbers, we held clinics on quite a few evenings. It was 8 evening clinics in total, including our first day at the hotel. Between 15 and 35 patients assessed at each clinic, and a total of 144 patients were seen by over 30 clinicians from both McMaster Family Practice and the Stone Church Family Health Team. So I think that was pretty remarkable, considering how quickly it came about. Reflecting a bit on this, this amounted to a global health situation really in our backyard, literally across the street. Many people who go into medicine, into family medicine in particular, have a big interest in global health. And, we had people with energy and skill and the motivation to make a difference here. And I think that's how this was able to come about as quickly as it did. Really as well as it did. Not many of us were experts in refugee health. Not many of us are experts in refugee health now either. But there was a motivation to help, and a clinical exam is a clinical exam. A diagnostic plan and management plan is a management plan regardless of where you are and who you're treating, and I think that really came out here. We had to rapidly adapt to some changing circumstances, as you've heard, and we were able to overcome, because people were committed to helping and getting over the hiccups and the red tape. I think many of you will be familiar with the fact that it's often difficult to make things happen quickly in big organizations. But at the end of the day, there was, hundreds of people within a city block of us who needed health assessments, and we have a team of doctors and allied health and administrative staff here who are able to contribute, and that's what was done, although it wasn't exactly pretty at every point in time. And I think, lastly, just a bit of a reflection on why we do what we do. I think it's easy to feel a bit of burnout or get a bit overwhelmed or lose track of why it is that we went into medicine in the first place when you're in a 5 days a week plus evening clinics plus weekends on call of 15 to 30-minute appointments. It can get a bit grindy. And I know for myself and for a lot of the clinicians who were involved in this who spoke with me afterwards, it felt almost rejuvenating in a way to be able to provide a service that was clearly needed to a population of people who were, very receptive and hospitable, and it was a great experience for us all. And it reminded many of us of why it is that we went into medicine in the first place. So I'll leave you with a few of the quotes that we got from some of the healthcare providers involved in this response. We'll be taking questions at the end, I think. Thank you.
Hi, I'm Laurel. I'm the nursing manager for the Hamilton Family Health Team, and I'll just give you just a little bit of a snapshot of what it looked like from my nurses' perspectives going into this. So as a community partner with Wesley, we started talking to Wesley in about November around helping them, seeing where we might fit into this process. Just to give you a perspective of who we are, if you don't know, we have a main office just on the other side of Jackson Square at 123 James Street North, so we're just like a hop, skip, and a jump from Wesley. And as an organization, we have 166 family docs spread over 95 practice sites, and I manage over 170 nurses that work in those practices. So we feel very strongly as a member of this community, as a large organization, that we have a role to play when we have these kinds of things arise. So in talking with Wesley through November, they were saying, oh, well, we have lots of experience with these populations, but we don't really have any clinical staff. We have great support workers who have a good sense of health needs of these folks, but they don't have the clinical expertise. So we said, okay, that's doable. We can do that. So starting in December, we put an RN in place working alongside their support workers, and a very experienced RN, and she was there full-time going between the two hotels. And she helped the Wesley staff just kind of triage people, answer people's questions, provide support, deal with minor issues like wound care and these types of things, and help the Wesley staff figure out who really needs to go to Emerge or elsewhere. That kind of went on through December, and just to correct Julie a little bit, at that time we anticipated 400 refugees by the end of January, not 1,000. The 1,000 changed after January. So you can imagine when we got to the end of January, we said, well, we have 400, we're good, we've done this. But we weren't good. And quickly, within over a weekend, we learned that we were going to have about 1,000, not the 400. So through January, the RN was there in the hotels. We quickly added a second full-time RN and then an additional part-time RN to support some of the immunization efforts. But what we did find is that lots of these folks have lots of chronic illnesses. I'm going to suspect, we can't validate it, but Hamilton seems to have received a lot of folks with a lot of health needs. And maybe it is because we have a pretty good support structure locally, and we're lucky to have that. But folks tended to come with a suitcase of medication and only enough for about a month. So into January, I said, what's going to happen here? These folks are going to run out of their chronic meds. We can't keep sending people to Emerge for these types of things. So quickly we determined we needed more help. And we needed help in the hotels. It was becoming increasingly difficult as the numbers increased to get folks out to walk-ins or other healthcare providers. So we brought in a couple of NPs, which quickly grew to 3.5 NPs over about a month. We have a good body of NPs in the Hamilton Family Health Team that stepped up. We paid them, of course, and it was outside their regular office hours. And McMaster Fit also contributed an NP. So we ended up having an NP in each of the hotels pretty much every day of the week to work alongside the RNs and help provide care to these folks. And when I say care, I mean these were some really sick people. As the resident indicated, there were lots of UTIs, lots of pregnancy concerns, but lots of very significant acute issues as well, wounds from war wounds, basically, amputations, these kind of things, infections, as well as the prescription renewals that we just wanted to make sure people were covered and they needed some clinical eyes on. And then we had a huge, massive burden of colds and flu, and as you can imagine, these people have never seen our kind of bugs. So as soon as they landed here, everybody had a cold or the flu, and it was a lot of supportive work to explain to them how we manage these kinds of illnesses here in Canada. So it was quite a significant burden, and as has been said, every day was a change. So every day we were revising our plan, bringing different equipment to the hotels. By the end of January, we'd put in place laptops with our electronic medical record, which happens to be Practice Solutions, but we were able to bring those to the hotels so we could make proper medical records for the folks that the staff are seeing. And ultimately, that's worked out nicely because those medical records can then go to our physicians that were absorbing some of these families. So I mean, a lot of it has been said, but I think the great thing about this experience is that we worked together. Everybody pitched in. Every one of my staff that worked in the hotels has found it a really rewarding experience, and the NPs that participated continue to go out to our family physicians' offices that took these families to support those visits, so we're able to continue that linkage. One of the NPs ended up going back to the hotel a couple of nights at 9 o'clock because she was worried about a sick child. And so they really sort of pulled out all the stops and helped out where it was needed most. I think one of the biggest learnings is we have to do this together. And hopefully, should we run into this type of situation again in the future, we'll be a bit better prepared. We've learned a lot from this, and that we can plan a little bit in advance to get these processes organized. But it's been a great experience, really. A lot of work, a lot of effort on everybody's part. And I think the families generally are well situated at this point. They've had appointments with specialists. They have a primary care provider. So now it's up to just moving forward and working on things like jobs and education. Thanks.
Thanks, Laurel. So, a deep breath, lots of good work happened, lots of good things have resulted from it. We're going to look at a few of the overarching principles of all that, and you'll notice that even just having this time slot today, trying to figure out how two organizations could actually sit together in the same room for a full hour and talk about things that they worked on together is actually really awkward. This time didn't really work for anyone that well. And it won't be this time after when we do it again, because it'll have to be a better one for all of us. But if we really want this work to happen, we're going to have to figure out how to do that and how we rearrange ourselves around it. You know, it's not everywhere that public health and primary care are funded so separately and accountable so separately. And I think the way we're structured from the top down speaks a lot to how we end up sort of connecting to each other in the trenches. And in our jurisdiction, this is one of the problems. It may have its strengths as well, but it's not this way everywhere. And even in primary care, we're already noticing that things that we thought about in terms of populations at one time, which was actually very little that we thought that way, is changing, and we're starting to have to think more about populations as we move into different structures like family health teams. So we could use this time to reflect on the resettlement process and what's that all about, but that's not what today's rounds really was going to focus on. Rather, we wanted to talk a bit about what does it mean to do public health and primary care together. So you've heard from Julie and Eric and Laurel some of those highlights, and I will try and pull a few themes through there. Sorry, my notes just fell down here. There we go. So if we think of settlement, good settlement as being all of these things, health is lost in there somewhere. And in fact, Wesley Urban Ministries, who met with these folks first and said, what is it you need now that you've arrived? For many, health wasn't even on the radar. We know we're the most important thing in the universe, but for them, they hadn't been convinced of it yet. Hopefully they are now. No, there's lots of other stuff that needs to happen with good settlement, but this is about as far as I'll go with that comment. We're not going to talk about that in a great deal more depth. You heard about the Wesley Urban Ministries being so pivotal. The other group was private sponsors. All the refugees that you heard about were government-assisted refugees. The private refugees actually were an industry unto themselves, and the groups that sponsored them learned a whole lot about what good settlement was. And a lot of it filtered over to those of us who were dealing with the government-sponsored refugees. So there was a lot of cross-fertilization and some things that they were doing in their own PDSA cycles that really helped us. And they weren't really at our table formally, but rather informally. And finally, the champions of the Syrian community. Very quickly, a few key people emerged as people who had really important backgrounds and training and skills that were perfectly suited to this situation, whether it was having a health background or knowing all the people who had come with them and that sort of thing. Those were very big assets. In terms of Wesley Urban Ministries, a little bit more about what they did with settlement. Their strategy was to identify needs on arrival, to do this full assessment. Their principle was to empower with knowledge to make informed choices to fulfill needs. They felt that their relationships with these individuals was going to be the most important feature, and that required trust, being consistent and being reliable, and this was mostly delivered through their case managers. Daljeet Gary is the executive director at Wesley, and she sent me a quote here to just describe a little bit about that. She says, "We had many instances of private landlords letting families move in without providing payment. They took our word that payment would follow. This was quite amazing. The other important factors are being responsive to the needs of individuals. This is sometimes where a relationship can break down. If they feel they're not being heard or their needs not met, it will negatively impact settlement and integration. The intensive case management piece is critical for government-assisted individuals and families as they are considered to be high needs. The case manager plays a critical function in ensuring folks are getting connected and staying connected to essential supports. These include health, education, language, and social supports. The fact that the case manager conducts home visits also allows him or her to monitor how the family is adapting to their new life. Quite often there's a lot of teaching that happens around family relationships and parenting." So probably the most important aspect of what happened with those folks. We've heard about this. I think the key is that in primary care, in Hamilton, primary care is a very scattered entity. And even with all the people we had at the table, we still really only had 60% of family medicine represented. There are still people in solo practices and not part of any group organization that would have had to be there individually. They weren't represented. And each of these different models, the Hamilton Fit, our Fit, the CHCs, are all funded in very different ways, which means that they have different interests, time available, ability to participate in being part of the response to a situation like this. So, person, population. All of us in this room deal with persons in our work. For some, it'll be very, very, very small amount of our work, and for some, it'll be most of our work. And all of us deal with populations. That is a group of persons to some degree, and for some, that will be most of our work, and for some, that will be none of our work. And there might be a bit of a difference between the people here who are employed in primary care and the people who are employed in public health. But it's not a clear line. It's a bit gray. If we think of persons coming together as all different sizes and shapes, and then deciding which collection of persons creates a community or a group or a population of interest, that's often not very easy to do. We do it on the basis of age, the basis of gender, on the basis of geographic delineation, on the basis of ethnicity. In this case, it was actually very easy. It was everybody who got off the plane, coming across the ocean from a certain place with certain kinds of papers, and arriving in this city. It was incredibly easy for us to say who the population was that we would want to focus on. It might not have been quite as clear to them that they were such a clear population. This did not include the folks who had arrived a year earlier from the same place. It did not include, there were people who were included in that group who may have felt like they actually didn't belong in that group as well. So for us, when we laid over a population definition to this, you can see that some of the individuals are sort of escaping the circle and some are more in the center of it. It's not still not perfect, even though this was almost as clear as we could have in our community. So they all shared a common characteristic, and then the funding, accountability, and leadership might be split between populations, population think and person think. So with public health having a different set of goals that it has to answer to its higher-ups, then primary care has to answer to, and those goals being mapped out quite differently and different incentives for doing that, doing something for this one group with whom we are all interested becomes a bit of a challenge. Therefore, we are here in this room together today. It might be possible to split it a little bit this way, though I'm aware that there will be arguments with this as well, that the population think is often about the disease, whereas the primary care think is often about the illness. The disease being what is going wrong with the person or what we want to prevent from going wrong with the person's body biologically. The illness being how does the person react to that? What is their experience? What is their worry? And so in primary care, even if we are asked to do a lot of preventive things and to be protecting people's health, it's almost impossible to do that if there's something else on their mind that day, and we can't leave the room without taking care of that first priority for them. In public health, there may be a lot of time spent looking at numbers and groups and delivering those numbers to their authorities. And in primary care, it's a different set of outcomes that we're interested in, although increasingly we're being asked to look at those group things as well. Public health might take care of things that are more about acute, transient, and crisis conditions, whereas in primary care we might spend more time on things like chronic disease management. So there are many different bodies that have tried to articulate what it takes to do good collaboration between public health and primary care, and this is just one of them from the Institute of Medicine in the U.S., but they're often similar. And you've heard these already, that there's a shared goal. There needs to be a shared goal. There needs to be community engagement to define the needs, hear from the folks who were there to serve, shared data. And as you heard today, one of the things that really propelled our work together was to finally have data where all of us would know how far have we gone with this, how close are we to being finished, how many of these things have we done. And before that data ability was set up, it was really a mess. It was swimming and wondering exactly where everything was. So that shared data is very important. And with that is communication. And I think Julie mentioned Chris Nagel, who was absolutely pivotal. All data and all communication went through him. And finally, that there's aligned leadership, that it bridges disciplines, that it clarifies roles, and there's the capacity to initiate and manage change. In our case, really, the fact that we had most of primary care there really helped. The fact that everybody who was at the table brought their best selves. It does, in the end, come down to personalities, folks. It still matters. How we treat each other and how we listen and how we adapt and what we're willing to give up. And at this table, all of those were open. So everybody came with strong opinions and also came with open minds. There were organizational decision makers there. Everybody could go away from the table and make something happen back in their organizations. Didn't need to go through multiple steps when they went back. Everybody was flexible, as you heard. Everybody brought lots of creativity. There was rapid change, great communication. And finally, the newcomers in this case were absolutely fabulous to work with. I think everybody was quite touched by what an amazing group of people these were. That helped our work a fair bit. So in conclusion, what does this mean for what other things we could be working on in a similar way? This won't happen this way in this exact fashion ever again. There might be something that happens this way in a similar fashion, but there are many, many other things that we have in front of us every single day and we've had in front of us for the last decades that we've tried to work on in our own separate ways. Does this have anything to teach us about what we could do differently with many of those things that we've already been trying to work on? And that's the end of the talk this morning.
So I wanted to thank all four of our speakers, and I think we probably have about 5 to 7 minutes for questions. And so I would open up questions to the audience. Yeah, Donna.
I don't know if anyone from dental's here, but this was identified very early on in the response that there were significant dental needs, both in adults and children. And if you don't know, public health has mandated our coverage mostly in children. The dental program worked with Wesley to go on site, completed a number of dental screenings. And you may not know, but recently the government has done increased funding to adults, because that was an identified need, and Wesley and other RAP centers advocated to the province and the feds, so there is more funding now for adults. No, in general. Like they have access to funds that they could take to other dentists.
Danielle? Are you thinking specifically about the Syrian refugee group?
Actually, we've talked about that exact thing in our leadership as early as yesterday. We were at a retreat. And as I said, we have 166 physicians, so it's about half of the population, and many of our physicians are in the process of retiring, this kind of thing, so young, new physicians are taking over practices. And over the years, those practices have dwindled a bit, so they want more patients. And in fact, in Hamilton, we have physicians clamoring for patients now, and we're recognizing out of this that immigrants, newcomers, refugees are going to be a significant source of those newcomers moving forward, or those additional patients for practices. So we do need to wrap our heads around it. And I know we've talked to McMaster-Finn, and we're going to have ongoing discussions about, what approaches do we need to take? Our practices need access to interpretation, so we've provided our practices with access to telephone interpretation, which has never been a problem before, but they do need it for this kind of work, at least for that initial period until folks can communicate effectively. So there's little things that we need to do, but we do recognize that it's a problem and it's an issue that we need to wrap our heads around, because it is going to be that growth area in our community. So I don't have an answer to it, but just to say that we're working on it, it's at the forefront of our thought, and we'll continue to develop some strategies around it.
The Mayor's Advisory Table, there's about 20 of us, and I'm chairing with Kathy Risden the health group. This exact same issue was addressed, because right now the advisory committee is for Syrian newcomers, and we talked about this is one group of newcomers. How can we take, and we need to deal with that now, but how do we take the lessons learned and the structure we have in place to make this can be an ongoing functional group to deal with any newcomers that come to Hamilton. And I think the primary care group that many of the managers from the clinics were on have also talked about, we came together and did some amazing things. How do we keep these relationships going? And how do we look at other populations or issues that we might work on together that we can use lessons from this and translate it into other successes?
Yeah.
So you stumped that, Susan. No. A little bit, I think, but very informally. And I think your question's a really good poke we need to think about that. Definitely, people are hearing anecdotally as patients come back in and are assessed again. We know that about half of the people we did initial assessments on in our organization have left us, and we're hearing that it's because they've moved to other parts of town, which the geo-mapping helped that you heard about to know exactly where they are, and could they be aligned with somebody much more convenient to them. That made a lot of sense when it was the hotel next door, but it did not make a lot of sense when they're up on the East Mountain or West Mountain, whatever. So a lot of work was actually done to realign them with other places. And so that's one piece of something that we know is that we're not the right place for everyone. Many also actually found docs who speak their language, so that was good to hear. So I think that's a wonderful outcome. But what they thought of the process as it went on was very anecdotal. And we did ask some questions as it went along. One of the big questions was not doing the assessments at the hotel and moving them over here across the street a good thing or a bad thing? Because we had thought so hard about making sure we were in their space, you know. They were across the board thrilled to have moved over to here. That's what normal people do, they said. That's what they do. They go to see their doctor at a clinic, not in their hotel room. So, you know, it's interesting how we have an idea, we do it, and then we only know after we ask whether it was the right thing or not. But no, not formally, so that might be something worth doing. I wonder if there are any MPH students in the room who would like to do a research project.
One thing I will say is we acknowledge that in the acute phase, we were so focused on getting immunizations done and health assessments, we didn't step back. Moving forward, Kathy and I have talked about for the health group, we want representation from one of the Syrian refugees to say, like, we're planning all this for you. How does this look? And the mayor's table is specifically called Syrian newcomers because that was feedback. They want to start hearing that they're not refugees right now. They're newcomers. So I think Wesley is involving them actively, and there is informal mechanisms, I would say, to get feedback, but we're being more planned about how we will have that feedback and how we will involve them in planning moving forward.
Okay, last question, David. So I think what we've heard today is really about, some of the early successes in coming together, but I think, hearing some of the comments and questions from the audience, the need that this isn't a problem that ended. This is something that we need to continue to address. And I think some of those relationships that have really been strengthened through the process will contribute to that. So I want to thank all of our panelists again today for all of the work on this issue, as well as coming and sharing your thoughts and experiences. I'm personally very thrilled to see how many people came out to our inaugural rounds, even though we know it's not the best time, so really appreciate that. And if you don't mind filling out an evaluation form, we will be taking some of that feedback, and we'll be trying to look for more rounds in the future. So thank you so much.